they immediately start testing that, because if that side of the brain is asleep and that's the side that your language and memory is on, you're not going to be able to speak. You may not be able to understand what they're saying.
I remember thinking, oh my gosh, this is such a cool and helpful study. And then the patient that went in, they remembered and didn't remember on both sides. The neurologist, epileptologist at that time was saying, this is unfortunate because there's so much that this patient is doing both left and right side that if we take too much, it would have completely disrupted their quality of life. Okay, so Shannon, unfortunately, there's a lot of people out there with epilepsy who their seizures aren't controlled or aren't well controlled by medications alone.
Mm-hmm.
And surgery is their next step, right?
Yeah.
Can you walk us through the evaluation process of being considered to be a surgical candidate?
Yeah, absolutely. So typically, you have your typical epilepsy evaluation. You have your outpatient EEGs, your inpatient EEGs, and then they'll trial you on medications. For patients who are surgical candidates, they need to fail multiple medication regimens.
Mm-hmm.
Sometimes, as you know, it's not just monotherapy, it can be polytherapy with several different ASMs. But once they've tried and failed a few different regimens, then they'll propose that surgery may be the next step, and that's when a whole line of diagnostic tests will be put into place. So it starts, of course, with another EEG. Sometimes they'll do, instead of a 10-20 array, they'll do a 10-10 array. They don't necessarily do it for the whole head, but possibly where the epileptogenic zone is, they'll add some 10-10.
When you say the 10-20, the 10-10,
Yeah.
explain a little bit about what that actually is.
Yeah. So the 10-20 system is the international system for how to measure and place electrodes on the scalp.
Mhm.
It uses landmarks such as the bridge of your nose, the back of your head, and then your ears as landmarks, and then you take certain percentages of those measurements. That way, barring any abnormal brain formation, you're in the correct spot for what you expect to see with those electrode locations. So the 10-20 is 10% and 20%, and the 10-10 is 10% and 10%. So it just puts more electrodes closer together over the scalp, or at least the area of the scalp they're concerned about, to try to pinpoint, have more specificity,
Mm-hmm.
make it a little easier to find where it is. Whereas the 10-20, you're more looking for it in general.
Okay, so if there's a specific place, I would imagine they're taking the 10-20 measurement first.
Yes.
And then they find out there's a focal epilepsy. They add the 10-10 measurement system to kind of narrow down and really localize that focal abnormality.
Yeah, absolutely. And it's not necessarily every patient that they'll do that for, especially with our diagnostic procedures that we have now. You don't necessarily need EEG to be that localizing, but it certainly helps in different situations, especially with temporal lobe epilepsy. That's probably the most common use I've seen of the 10-10 system.
Mm-hmm. Okay, so going back to the original question, so let's say they failed maybe the routine treatments. What goes on from there?
So from there, they would do a series of diagnostic tests. They'd likely have a repeat CT or MRI to get a good picture of their brain, make sure there's not any lesions in the brain or anything structural that's causing the seizures, because that makes a quick fix. If there's something structural, you just solve the structural problem if you can. So they'll do CT or MRI to get a good picture of the brain. And then if they don't have a clear answer as to where the seizures are coming from, they'll do other tests. So there's a test called like the PET scan, and that is it's a radio tracer. So they inject a dye essentially into your body, and they see how fast it's metabolized in your brain, and that will show kind of where there's areas of concern. There's also an ictal SPECT, which is very similar, and they do that at the time of a seizure. So you'll be hooked up, ready to go, And then once a seizure begins, someone will push that radio tracer and it'll see how it metabolizes in your brain.
Interesting.
So it's kind of a real-time sort of test.
And do they do that bedside, or do they have to actually go into some type of special room?
Yeah, it would be in one of the radiology suites.
Okay.
Because they'll need like a CT.
Yeah.
CT.
So are these patients who are having multiple seizures a day? Because as we all know, seizures can come and go. You can go weeks
Absolutely
without having a seizure. And then, so these are patients who are really having uncontrolled seizures daily, to where you can actually assume that they're going to have one that day, get them prepared, put them in, maybe take their medications, their therapy off, and just unfortunately let them go, really, and have these seizures so they can catch them. Is that right?
It can certainly be that way. It's not necessarily a prerequisite that you have daily seizures to have any of these, but the prerequisite is more so that it's devastating to your life.
Right.
So improving your quality of life. If you have one seizure a week, but it's a 10-minute, generalized tonic-clonic, or grand mal as it used to be called, and you break your bones, or you bite your tongue, or if you're having drop seizures known as atonic seizures and you're falling, hitting your head, that is considered devastating.
These are seizures that can completely disrupt someone's life.
Yes.
Right. And these are the ones that, hey, we've got to figure something out. What about things like, absent seizures, or kind of where people kind of stare off, maybe JME? Are these candidates for, what'd you call them, specs?
Ictal specs. Not necessarily, because a lot of those seizures are generalized. So an ictal spect is most helpful in patients that have focal seizures, and trying to localize where that epileptogenic zone or where the seizure is coming from in the brain. So the generalized seizures, such as the generalized tonic-clonic, we know that it's generalized. Oftentimes, those types of seizures do have a very specific focus, and it very quickly goes to both hemispheres of the brain. However, for absent seizures, they are generalized. And so there wouldn't be one particular spot. We would just know that they're happening. Same with atonic seizures. They are generalized seizures. And so it wouldn't necessarily be helpful for them.
Yeah.
But that would be kind of, especially for focal epilepsy, that would be kind of the next step, would be to do either a PET scan or an ictal spect, or both.
So you had mentioned maybe doing an MRI or a CT to see if there's any structural lesions that are actually causing these seizures. What is the success rate of finding a structural lesion and actually removing that from the patient and them being seizure-free? Is that a surefire way of stopping these seizures, or is it just a part of the process to figure out what's going on?
Yeah, typically, yes. If it's a structural issue, like a lesion on the brain, once they remove that lesion, typically patients are seizure-free. They may remain on an anti-seizure medication prophylactically, just to make sure that, especially after having brain surgery, a lot of times they'll be put on Keppra, for example. Keppra is kind of the catch-all anti-seizure medication. So they'll be put on something just to make sure that they are okay. But then with repeat EEGs afterwards, they may be able to wean off anti-seizure medications entirely. The biggest issue is where the structural lesion is, and if it can be safely removed without damaging what's called the eloquent cortex, or language, memory, even muscle and senses. So it's important to stay away from the areas that we need to have a good quality of life.
And I know what diagnostic test that is, but before we go into that, so we can paint this picture for the listeners, a patient comes in, they do routine EEGs, ASMs are then prescribed. They take these ASMs for a certain amount of time, I'm assuming. They're failing. They're continuously trying to make quote unquote cocktails, right?
Yes.
Of these seizures, seizure medications, and they keep continuously failing these, keep having EEGs still showing epileptiform activity. Then they go through these other special diagnostic testing that you just mentioned. Okay, so now we're up to speed to that. Are there more diagnostic testings that they need to go through after that?
Well, there's a few different things they need to establish. They need to establish what hemisphere of the brain language and memory is on. Typically, for those who are right-handed, it will be on the left side of the brain for both language and memory. It's usually, I think it's about 70% of right-handed people, maybe a little bit higher. And then for left-handed people, it's 50-50 on if it's left or right side of the brain. So they need to do a diagnostic test to see what side of the brain language and memory is on. There's a few different tests they can do, one of which is called the WADA or the ISAT. I call it an ISAT because that is how I learned it.
Yeah. Terminology is always changing.
Yes, so, it's always changing.
So go through what this acronym actually means, both the WADA and because I had always heard it called WADA. You call it an
ISAT. So it's intracarotid sodium amytal test. I think is the T.
And that is the chemical that they actually inject it through the leg. Correct. That goes all the way up.
Yes.
And then there's a CT, right?
It's in an interventional radiology suite.
Okay.
And the patient will have EEG hooked up. So how it works is before they go into the suite, they will have a baseline EEG. It's usually just a few minutes. I ask them a few questions, kind of like your typical bedside EEG. And then once they are in the suite, they will have the EEG running. They'll pick which side of the brain they're going to anesthetize, essentially. They're going to put the brain to sleep.
And who's all in this process? Is it the anesthesiologist? Obviously, the neurologist is there. Yep. Who else is a part of that? Radiology
So
techs,
there will be a neurosurgeon, the epileptologist or neurologist, whoever is working with the patient, the EEG technologist or clinician. Sometimes they have intraoperative monitoring technologists in there. The place I worked at, it was EEG that did these tests. They'll also have radiology technologists. They all have different purposes. It's just like in a regular operating room setting. Everybody has their own purpose.
Yeah.
So they'll insert a catheter through the groin up into the brain. They'll put one half of the brain to sleep. And immediately we make sure that the side of the brain that they're attempting to put to sleep is the one that's asleep via the EEG. So those lines will go flat.
Yeah. And they're doing it, sorry to interrupt, but they're doing it with
sodium amytal or amibarbital.
Yeah. I've actually been on the other side where I get to see the chemicals going through it. And it's, y'all, if you haven't seen it, if you have WADA testing at your hospital, go check it out. It is
so cool.
It is wild.
It's so cool.
It is. It really is. And it's so helpful for these patients, hopefully. But it looks like, you've probably even seen it on commercials or movies, because what happens is this dark dye, right, goes through, and you actually see it going into the cranial veins, and really actually get into the brain. It's absolutely quite astonishing to see.
Yeah, it's super cool.
Yeah. Okay, so sorry to interrupt.
You're fine.
How would you describe what's happening, what that chemical is doing to that part of the brain? They're just kind of putting it to sleep?
Yeah, so it's very similar to when you're put under general anesthesia for surgery. Your brain activity lessens, and a lot of that is because of the type of chemical they're using, type of medication, but it's to help protect your brain. So that's for general surgery. For this purpose, they're injecting this medication into one hemisphere of your brain, and that hemisphere, until it circulates via like the circle of Willis, which is the collateral circulation system of the brain, it'll stay asleep for about a minute. And then it starts coming back because the blood flow is circulating that short-acting medication.
So when you're in the room with the patient, what is their physical demeanor like? What are their clinical symptoms of this medication actually kicking in?
So they'll be on the table, kind of strapped down for their safety, of course, like just so they don't roll off mostly.
Yeah.
We're not very concerned with people hulking out and
yeah.
getting violent, but it's so they don't roll off. But they're typically just laying still anyways, But as soon as that medication takes effect and that side of the brain is asleep, the psychometrists, neuropsychologists, I believe social work is often in there as well. They will start going through a very specific set of questions. They'll put pictures and have them remember as many as they can, have them say a word. It's to test their language and their memory, as well as kind of spatial considerations too. So they immediately start testing that, because if that side of the brain is asleep and that's the side that your language and memory is on, you're not going to be able to speak. You may not be able to understand what they're saying because that's where your receptive speech is.
Right.
And then as it slowly starts coming back, then that's how they test the memory, because you'll eventually be able to speak, but maybe you don't remember that they showed you a blue duck or, a red pencil or whatever the photos are.
So the patient goes through this hemiparalysis, and they have one side of the brain working. They're alert. They're looking. In my experience, they definitely seem altered, like they're really struggling. I remember again. I've heard that it's maybe have seen 2 or 3, but enough to impact my memory, and this is why I'm chiming in so much, is because it was such an experience. And 2 patients, one was really successful. The second one, not so much. The first one was having issues on focal seizures on the right side. When they paralyzed the right side of the brain and the left side was working, he remembered every picture, which is optimal, right? Like that's ideal. That's what you want, because when you completely paralyze the right side, you know that the right side isn't controlling these functions.
Exactly.
That, like you just explained just a minute ago. So I remember that patient doing perfect, remembering everything on the left side when the left side was active. And we were like, that's a great case. And that was my first case. So the second case I went into, I remember thinking, oh my gosh, this is such a cool and helpful study.
Yeah.
And then the patient that went in, they remembered and didn't remember on both sides. So the neurologist, epileptologist at that time was saying, this is unfortunate because there's so much that this patient is doing both left and right side, that if we take too much of the right side out, or the left side, I can't remember what part was having issues, focal epilepsy, it would have completely disrupted their quality of life. And so I believe, and maybe this, I don't want to jump into what happens next, but I believe there was a VNS solution for that. I don't remember, so I'm going to kind of pass this on to you. So after a WADA test, after let's go down 2 paths where they pass the WADA, they can go in for surgery. What does that patient look like?
Well, before we jump into that, I forgot to mention WADA is not an acronym, unlike basically everything else in our field.
Oh, I didn't know
it's
that.
named after the person who quote unquote invented it.
Okay.
Which is why I don't call it that, because he was not the first one to do it. He just was the first one to name it after himself.
Very good.
So Dr. June WADA.
Okay.
But I don't remember I should know the name of the person who did it first, but it was a surgeon out of Cleveland Clinic that did it for, I think it was like 1964.
Okay.
That he did, or maybe 62. I don't remember.
Well, I'm done with WADA. I'm done with calling it WADA.
It's an ISAT.
Okay. All right.
But everybody calls it WADA, so you can call it WADA. It's okay.
I'll probably call it WADA again. I'm not going to lie.
But
Accidentally.
There are some patients where a WADA isn't necessary. Now I'm doing it. Where a WADA isn't necessarily the best choice. There are also options. There's one called a functional MRI, and that essentially kind of replaces it's a non-invasive test, which is nice. Yeah. So they'll hook the patient up to EEG electrodes, again, likely in the 1010 array, so that more densely populated array of electrodes. And then they put them in an MRI and they ask them a series of questions, and they're checking to see the areas of the brain that are activating during those things. So that can also establish language and memory dominance. It does not have to be an ISAT, especially because that is an invasive procedure. There's always risk anytime you puncture the skin of infection, and some patients it's just not the right tool to use.
So could this completely replace the ISET/WADA test?
I think so.
Yeah.
I haven't personally done enough of them to have a solid opinion on it.
Right.
But I have seen how well they work. Either a functional MRI or an MSI, which takes the magnetoencephalography, which is essentially kind of the same thing as an fMRI, just little different application.
Mm-hmm.
But they'll do the same thing. They'll put them in this machine. They'll have their EEG electrodes on their head, ask them all the questions, have them do the tasks like tapping their finger, twiddling their toes, whatever it may be, just to establish where the motor cortex is and the sensory cortex, and then where their language and memory is. So there are different applications, and I think it probably could. I think a lot of it is just the facility's capabilities. A lot of times they don't have the ability to do a functional MRI, but almost every facility has an interventional radiology suite. So it's a lot easier to service these patients, even if they don't have the state-of-the-art setup.
Yeah. Actually, I was thinking to myself, I don't remember doing those tests much, and I wonder if it was because I was, it was 2004 and I'm an old guy in this industry, or if it was the facility just not having it.
Yeah.
So it's case by case basis on
Right.
if these facilities can actually perform these
Right.
studies. Okay, so
And also, it may not even just be that they have the ability to perform them, but if the patient isn't going to go through with the epilepsy surgery evaluation at that facility, then they'll likely have to or want to repeat those tests at whatever facility they do decide to go through, because you want continuity of care.
absolutely.
So a lot of times it'll be, well, we won't be able to help you to the very end.
Right.
So we're going to send you to this facility or refer you here, and they will do the workup, because
That
then,
makes sense.
everybody has their own policies and procedures and the way they like to do things. So typically it's a lot of that.
Yeah. And I know if I was a patient, that's exactly what I'd want to do.
Mhm,
I would want
100%.
to, if I had to redo a test, at least I'm going to redo the test with the people that I have an end goal with.
Mhm.
So speaking of end goal, so going back to this patient, so they go through this other testing,
Mhm.
and then what actually is determining the candidate? I'm assuming we're getting close to actually a green light on the surgery.
Mhm.
Is that correct? So what
Yes.
is that next step of all these diagnostic tests?
Yes.
They're failing the seizure medications, but they're passing these diagnostic tests to be
Yes.
candidates.
Yes.
So they're having bad news and good news, and we're
Mhm.
going with the optimal patient. We're going with
Yes.
the luckiest of the ones who are actually going through this process.
Mhm.
The diagnostic testing says they can go through surgery. What is next after that?
So after they have the tests to localize where the seizures are coming from, like I said, it's typically the EEG, the PET scan, ictospect, CT, MRI, those types of testing. Then they'll have the testing to ensure that the area that they would the area that they would theoretically take out is safe to remove. So then that's the language and memory, like the ISAT or functional MRI. So they found it, they made sure the area around it is safe. And let's say our patient, we'll call her Jane, 8-year-old female, focal seizures. We'll say right temporal lobe epilepsy.
Okay.
That sounds good.
Yeah.
So she has left language and memory. The right side seemed to be all clear. So now they're going to discuss, okay, where are these seizures coming from? Is it a big spot? Is it a small spot? And she would likely move forward with epilepsy surgery treatment. So since she doesn't have language or memory in that hemisphere of the brain, it's a lot safer to take out the entire temporal lobe. They may not take out the entire lobe. If she had a lesion, for example, they would probably just take out where the lesion is, maybe a little bit extra, but it would be a very small amount that's taken out. But if it's kind of widespread from that temporal lobe, which is very common. Temporal lobe epilepsy, I believe, is like 70%
Yep.
of epilepsies. They would likely take that entire temporal lobe out. So then they would need to decide, well, we're getting a little ahead of ourselves, because what if it's not the entire temporal lobe? And what if it's a structure that's deeper and they don't need to take out the whole thing and they can just take out a little bit?
How do you do that?
So my favorite thing, stereotactic EEG, also known as SEEG.
Yeah.
So they'll take all this information that we've compiled. Typically, there will be some sort of surgical conference with the neurologist, neurosurgeon, epileptologist, the psychologist, psychometrist, social work, because they need to make sure if you're having all of these procedures that you have the social support as well. Typically for children, you have your parents, but for our adult population, they need to have somebody who can be there with them, and they're not going to be able to go back to work the day they get home from the hospital and things like that. So making sure that socially it is a good fit for them as well. So there's lots of different cooks in the kitchen, but all working together. Like one of those like Michelin star kitchens, everybody has a job, but there's lots of people. So that's where the SEEG planning comes in. And that's a huge portion of this epilepsy surgery candidacy process. And not everybody who needs epilepsy surgery needs SEEG. So it's more so when they're trying to even further localize, because they want to minimize the amount of brain they take out.
Right.
This is really common in patients that maybe have memory and language on both sides, so they need to get as focal as they possibly can.
Right.
So the SEEG process, the neurologist, epileptologist, neurosurgeon, they'll all conference and plan out where they want these electrodes to go. So stereotactic in layman's terms just means like in and deep. So we're putting electrodes into the brain instead of sitting on the scalp.
Also known as phase 2?
Phase 2 monitoring,
okay.
Yes.
Because I was actually in the back of my head before, when I was thinking moving on after the diagnostic testing, I was about to say, someone is listening, screaming, phase 2?
Yeah.
What about phase 2?
Yeah.
And then you said we're jumping ahead of ourselves. So
Yeah.
I love that. Okay, so keep going. So there's electrodes that are placed, and those are called grids.
No, so grids and strips are different. Those are, it's still technically phase 2 monitoring.
Thank you for watching the CortiCare Podcast. We hoped you enjoyed it. Stay tuned, because this episode with our special guest will continue in the following weeks.